any stage, let me know if I get you in your way. I'll try and stay out of the...
This thing doesn't go, it doesn't have a very wide angle.
Okay, good evening everyone. Thanks for coming. I thank you for taking time on Saturday to join us for one of our favorite events that we'd like to organize, and I'm glad that you guys today. So my name is Ubaka Owogo, and I'm an assistant professor and the case research fellow in the Faculty of Law at the University of Alberta. I'm also a member of a group known as the Health Law and Science Policy Group, and I also work with the Health Law Institute, both of which are institutions at the law school here at the University of Alberta. So we do work in health law and science policy and research on issues relating to healthcare, medicine, biotechnology, and science policy in general. And we like to put up this event as a way of bringing experts in the field of health sciences and health law and science policy to engage with members of the public and have a conversation about some of the issues that we encounter in our research. So we've done a number of these events in the past, and it's always a lot of fun. It's like having coffee or a beer with friends. It's a time to sit down, have a discussion about a very controversial, topical subject, and get a sense of what the public think about the subject, because we only see it from the perspective that we're studying from. So I'm very glad that you will be here, and I encourage you to think of this as having coffee with friends, like I said before, and to ask questions, offer an opinion. Basically, it's a free-for-all. So you're welcome to say anything that you say to your friends. You're welcome to engage in a debate, argument, discussion, ask any question that relates to the topic. So this event is sponsored by the Canadian Institute for Health Research and by the Health Law Institute and the Health Law and Science Policy Group. It's called the Café Scientifique, which I believe is French for Science Café. And CIHR, which is the Canadian Institute of Health Research, sponsors a number of these events each year. Typically, researchers around the country apply for funds, and they support this event as a way of bringing the members of the public together with experts to talk about the topic. The topic for today is medical travel for stem cell treatments. And we have assembled here today for you an excellent and highly knowledgeable panel of experts to talk about this topic. I'll introduce them very briefly. The format of the event is we'll have our experts speak for 5 to 10 minutes. So it'll give you some kind of background on the topic. And after that, we'll pretty much open it up for discussion, and you can ask questions, contribute an opinion, while you're having some food and enjoying a drink. Now, drinks are on the house, so feel free to have anything you want. It's all paid for by the taxpayer. If you don't enjoy your money, this is one opportunity to get to enjoy your money, so please take advantage of it. And so thank you, taxpayer, for organizing the event, for funding the event. So I'm going to introduce the experts. They'll speak for 5 to 10 minutes, and then we'll open it up for discussion. So first up is Dr. Peter Bell. He was born and raised in Edmonton, where he completed his undergraduate medical training and residency in family medicine at the University of Alberta. He currently works in an outpatient-based family practice at the Royal Alexandra Hospital with a specific interest in clinical teaching and palliative care. He's going to be offering his expertise from a doctor's perspective. He's going to be talking to us about how doctors approach this issue of medical travel for stem cell treatments. Thank you, Pete, for coming. And sitting next to Pete is my good friend and colleague, Professor Timothy Caulfield. Tim is a Canada Research Chair in Health Law and Policy and a professor in the Faculty of Law and the School of Public Health here at the U of A. He's also the Research Director of the Health Law Institute and the Health Law and Science Policy Group, and he's a Senior Health Scholar with Alberta Innovates Health Solutions, as well as the Principal Investigator on a large number of projects. Tim and I have been working together since 2005. He's highly knowledgeable on a number of subjects relating to health law and science policy. He has written over 250 academic works, including his latest book, which I recommend to everyone. You should totally get it. It's called The Cure for Everything: Untangling the Twisted Messages About Health, Fitness, and Happiness. Tim will be offering his expertise on the issue of stem cell tourism, or medical travel for stem cell treatments, which is an issue we've been studying since 2007, I believe. Great speaker. I'm looking forward to his talk. Sitting next to Tim is Aline Hyun. Did I say that right? Yeah. Aline joins us from the Alzheimer's Society of Alberta and Northwest Territories, where he has worked for 12 years. The primary focus of the Alzheimer's Society is to help people with Alzheimer's disease and their family members through the dementia journey by providing education and support services at all stages of the disease. Aline is here to speak about how patient advocates will approach the issue of medical tourism for stem cell treatments. Thanks, Aline, for joining us. And lastly, I have Dr. Greg Corbett, who is a professor of surgery in the Department of Surgery here at the U of A. Greg his main area of research is islet cell transplantation for the treatment of type 1 diabetes. He's also the scientific director of the Cell and Tissue Innovative Research Center, which is a good manufacturing practice facility for processing clinical grade cells and tissues. So that's a way of saying he's a highly qualified stem cell researcher, and we're very, very pleased today to have him join us. He's going to be giving us the science perspective on stem cells and stem cell treatment. So I'm very, very excited to have this panel of speakers. I think this is the best group you can assemble to talk about this topic, and I'm very grateful for them taking time off their busy schedule to be here today to speak to us about these issues and to have a discussion with us about this issue of medical travel and stem cell treatment. So I'll ask Tim to start by giving a general overview of the subject, and we'll take it from there. Thanks again for coming.
Well, thank you very much. I'd like to first of all thank Ubaka for putting this together. You did a wonderful job, and thank you for coming to listen to us on this Saturday. And please feel free to get up and get more food, or to get one of Levin's amazing coffees. I am going to give you a general overview about stem cell tourism and about medical tourism in general. This is a topic we've been studying for a long time and we feel very passionate about. Now, the topic of stem cells, as Greg will give you more detail, is incredibly exciting. It is an incredibly promising field. And it is a field that's got a huge amount of media coverage over the last, since 1997. Right? Huge amount of coverage. So the excitement is there, and the excitement is real. So what is stem cell tourism? What is the topic? How many people here have heard the term stem cell tourism? I know quite a few. So stem cell tourism is a large global phenomenon. If you went to your computer and you Googled stem cell therapy, you would be met with a search that would take you to clinics all over the world. And these clinics look phenomenally sophisticated. These clinics are in China, they're in India, they're in Mexico, they're in the United States, they're in Germany. They're all over the world. And they're offering stem cell treatments for everything that you can imagine. You can get, of course, in these clinics, a stem cell treatment for everything for ALS, for anti-aging, we all need to deal with that. You can get it for a variety of cancers, for a whole range of other neurological disorders. You can get it for cosmetic reasons. You can get it for sports injuries, on and on and on. You can get a stem cell therapy for just about anything you can imagine. And these therapies are not cheap. Our research has shown that they range somewhere between $20,000 to $50,000. So what we did in 2008 was just as this phenomenon was growing steam, we thought we're going to get a sense of what's going on. So we studied what the clinics were offering all over the world. We wanted to get a sense of what they were offering and how what they were offering mapped with exact scientific literature. It's not going to surprise you what we found. We found that in 2008, these clinics were offering treatments as if they were proven, as if they were completely routine, as if they were risk-free. And when we mapped that, we worked with an interdisciplinary team, we mapped that against the existing literature, and virtually all of them, giving a rough brush here, virtually all of them had no scientific literature to support their use. Really none of them. Now, just recently, I guess the paper was accepted just weeks ago, right? We redid this study, and we found, in fact, it's getting worse. It's getting worse. Not better, but worse. So that was very disappointing. In fact, our hypothesis was that these clinics were going to be sort of moderating their language, and they weren't at all. It was, in fact, getting worse. So one could say, so what? Why? What's the big deal? If people are going in with their eyes open, if people are truly informed, right, then why not? I think that's a legitimate point. If they feel like they know the true risks and the true benefits, if they know this stuff is really experimental, and this is a last sort of ditch effort, maybe it is hard to argue that they shouldn't be able to go. But we feel that they are not being told the truth about these services. We feel that perhaps, at least in the public face of these services, it's being misrepresented. So there is true financial harm associated with this. And this is a story that I love to tell about. There's a couple heartbreaking stories about this. This is one I like to tell because it's relatively recent. Early December, I think, is that right? It was early December, a class in eastern Canada, junior high school, raised funds to send their classmate to China to get stem cell therapy that the school thought was going to allow this individual who's been blind his whole life to see. They raised, the kids raised $20,000 through penny drives and through their community to send this child there. And then they have this heartbreaking quote from the kid, "I can't wait to see the trees and colors when I return." And it's really heartbreaking. And they were holding, it was covered on CTV National News. And they were holding a dance that night to try to raise the rest. Now, it's hard not to get angry when you hear those kinds of stories, because we know the state of stem cell therapy is not there, right? It's not at that point. So you have that financial exploitation. You also have real physical harm. You have real physical harm. If you are injecting pluripotent, the reason stem cells are so exciting, is because they are cells that have the potential to become any tissue in your body. That's what makes them exciting. If you are in fact injecting pluripotent stem cells into the human body in an uncontrolled manner, harm can occur. And in fact, there has been documented cases of this. There have been tumors that have grown, and very recently, a woman went to Russia? Ukraine to get cosmetics. So she was getting stem cells. So the cosmetic industry is exploding. You can get stem cell creams that you rub on your face. And they're very, very expensive. So this woman was actually, she certainly was stem cells. She was getting stem cells injected in her face. Did you see this growth story? And bone started growing in her eye. Yeah, it's all kind of cute. It's really horrifying. So you have actual physical harm that can happen. In addition to that, you have harm to the scientific field, the legitimacy of the field, right? So I think that's another reason that entities like the International Society for Stem Cell Research are so interested in this field, because they're worried about how this is going to affect the legitimacy of the entire field. So one thing we're also interested in, this is the state of play. Does anyone have any questions about it? So we're very interested, how did this happen? How did we get to a situation where these kinds of services are being offered in such an uncontrolled manner? Well, part of it, I think, is, and Pete and I were talking about this earlier, part of it is that huge excitement around stem cells. We have all been told, right, for 15 years that a revolution is here, right, a medical revolution is here. I call it science exploitation, where you take something exciting, a legitimate field of science, and you exploit it, and you exploit patients. And I think that's what's happening here. Like they're taking a genuinely exciting field and using that legitimate excitement to sell bogus products. Now, the scientific community has to take a little bit of responsibility, for, I think, for hyping, particularly in early days, hyping the field in order to garner excitement. So there's that kind of excitement. And the media also has, I think, can take a little bit of blame. We've studied how the popular press has portrayed the actual clinics all over the world. And we found that almost without exception, the popular press portrays this area as in a very positive light. Just like the story I told you about the kids in Eastern Canada. That's almost always how it's portrayed. It's almost never negative, and increasingly so. It's a human interest story. It's viewed as an exciting, sort of heartwarming story. The efficacy is rarely questioned. So if you are a patient and you are desperate and you're looking for your cure, I can completely understand, given the excitement around the area of stem cells, you can understand why the family would take a child that they're desperate to treat to a place like China, to a clinic that looks completely legitimate, after being exposed in popular press to these all positive stories. I completely can understand that. So then the challenge becomes, what do we do? How do we move forward? How do we try to quell this problem? Well, it's going to be tough. And I think this, we're also talking about this, I think this is part of a broader phenomenon of medical tourism, right? Not just, I think we can learn from this, but it really is relevant to transplant tourism, it's relevant to genetics, it's relevant to a whole array of medical tourism. But the challenge is it's an internet-based industry, so it becomes very difficult to regulate. I do think we can work with family physicians, because there's some evidence that shows that when patients are making decisions about going to one of these clinics, they talk to their family physician. You're going to spend $50,000, $60,000, $70,000 on a treatment, and by the way, it's often more than that, because you have to fly there, right? You often stay for a long time, so it becomes hundreds of thousands of dollars very quickly. You're going to talk to your family physician. So we think educating family physicians, particularly in countries like Canada, where we have family physicians, is very, very important. That's one method, but there's other things that are controversial. We had an individual here from Harvard just a couple of weeks ago, Glenn Cohen. This is for discussion, see what you guys think. Glenn thinks that family physicians, now we found about 40% of these patients, just through the media analysis we did, are minors, or kids. Glenn Cohen thinks that family physicians have an obligation to report as child abuse under the child welfare laws. If they know a family, I don't know if that's true, we can talk about that, right? Very interesting. So there's that way forward also. And lastly, before I pass it over, I think Greg? Yes. I do think, because it's a nice segue to Greg, I do think the scientific community has a responsibility to somewhat moderate the language around the field, to portray the field a little bit more realistically. I saw George Daly when I was in Harvard just about a month and a half ago. And so George, I think he's still the president of the International Society for Stem Cell Research, a leading figure in the area of stem cells. And he told the crowd that day, so he's a stem cell researcher. He said most stem cell therapies won't be available for 50, maybe till 100 years. Does that sound too pessimistic to you?
It's pretty close, in my opinion.
So that's the time frame we should think. But you know what? And that's a blink of an eye in the scientific world. It doesn't feel like that to the people that need it right today. But I think that's the reality that we need to start grappling with. So that's a little bit of an overview. I'm going to pass it over to Greg and let him take us through the science.
Thanks, Tim. Well, what I'd like to briefly give you an overview of what's happening in the field in cell therapy. I don't always like using the word stem cell therapy because there's a lot of cell therapy out there that can be beneficial for a number of different diseases. So one of the earliest examples is a bone marrow transplantation. You have an individual who has cancer, leukemia. So what they do in this case is they take a bone marrow aspirate to collect, and then they irradiate the patient to kill off all the bad cancerous leukemic cells, and then they go in and transplant that bone marrow back into that individual. In that bone marrow, there are stem cells, among many other cells. So that's, as far as I know, is one of the first clinical cell therapy stuff that's actually happened and had benefits to patients. It's getting more sophisticated now with new technology, and now what they're doing is they're not transplanting the whole bone marrow back. They're transplanting subsets of cells that they know are the ones that are actually the most beneficial. So that, with the new technology, is advancing. Now I'd like to give you an example of what I call real, true cell therapy that has been a success in patients with type 1 diabetes. So when you're type 1 diabetic, you have an autoimmune disorder. So that means for some unknown reason, your body's immune cells think the cells in your pancreas that make insulin are foreign and they destroy it. So then you can't make insulin and you have to take daily insulin. I'm sure many of you here know of an individual with type 1 diabetes, and it's a very bad disease to have. Here in Edmonton in 1999, we transplanted 7 patients with type 1 diabetes with human insulin producing cells that we obtained from human organ donors. Since then, we've transplanted about 170 patients with really good success. It's been reproduced in a number of centers internationally. So this is what I call successful cell therapy. Other things that are in the clinic, in bone marrow, in fat, and in other tissues, we have these cells called mesenchymal stem cells. These cells have properties, secrete proteins, that can help prevent rejection of transplanted cells, but they also secrete factors that can help regenerate and repair damaged tissue. So what has been done with this? So this has been used in clinical trials for patients with MS. There are clinical trials out there for newly diagnosed type 1 diabetics, thinking if you inject these mesenchymal stem cells into these patients, it will help regenerate the damaged pancreas so that patient won't have to be on insulin. There are clinical trials here in Edmonton for treating patients with Crohn's disease. So these are cell therapies that are actually happening. They're called mesenchymal stem cells, but they're not a stem cell that can become any tissue in the body. It's only been shown that they can turn into bone, fat, and I believe cartilage. So there is a researcher here, 2 researchers, Natarjoma and his colleague Adatola, that are working, obtaining mesenchymal stem cells from bone marrow to generate cartilage for knee damage. They think that they're going to be in the clinic within 5 years. I think that's optimistic. So to give you an idea, how long does it take to get things into the clinic? Well, islet transplantation was shown in 1972 to cure diabetes in rats. It wasn't until 1999 that clinical trials actually went through. So we're talking almost 30 years. If you look at a pharmaceutical company, minimum 25 to 30 years from a discovery of a drug into a clinical trial. So for stem cells, so someone can say, oh yeah, I can take stem cells and grow an ear on the back of a mouse so I can do cosmetic repair. Doing something in a mouse is so far away from doing it in the patient. And that's why I agree with Tim. As a scientist, we need to take responsibility, because some of us in the field have not only great scientific minds, but extremely big egos. So they love the publicity. And it's easy to blow something out of proportion. An example of that is the Edmonton protocol. The media said it's a cure for type 1 diabetes. It's not a cure. It's changing one form of therapy with another. No longer daily insulin injections, but now an islet transplantation and daily anti-rejection drugs. So you have to weigh the risk to the benefit. So, and that for type 1 diabetes is not even out there for all type 1 diabetics. Actually for a very, very small group of patients. And that's what some of my research is. When you think about stem cells and the ethical issues, it's, I think, largely related to embryonic stem cells. Well, I worked for about 10 years on embryonic stem cells to generate insulin-producing cells. And in that 10 years, I could show a benefit in a diabetic mouse, but I couldn't cure its diabetes. I never saw once when we did a transplant that a tumor never formed. And in those tumors, when you look at it, there's a bone in there. And if you actually look at it underneath the microscope, you can see cells beating. They're heart cells. So that is so far away from being in the clinic. Because you may be lucky and be able to do something in a mouse with a couple of million cells. But to get therapeutic amounts of cells for a patient, that's a completely different story. Interestingly, there was, in the US, the NIH approved an embryonic stem cell transplant trial for the correction of spinal cord injury. This was spearheaded by a company, Geron. So obviously there was more than scientific interest in it, there was financial benefit. Everybody knew about this, and we're waiting to see the results. Suddenly, in the media, it was dropped. This company got rid of all of their stem cell research. No one knows why.
They say it was financial.
Yeah,
They couldn't make money at it.
They probably also knew it wasn't going to work.
Yeah.
So that's ages from now. I like doing it because I found it interesting. It was cool for me to work with the cells, but knowing that in my lifetime, it's never going to have a beneficial effect. So to talk about stem cell tours, so I'll give you an example that I personally experienced. I am also really interested in transplanting pig insulin-producing cells into patients with type 1 diabetes. I've been working on this since 1994. I've cured diabetes in rats, mice, pigs, adult pigs, and with collaboration from the group in the US, non-human primates, monkeys, which is the golden preclinical standard. Now I want to go into the clinic, but I have to convince Health Canada. So when I was working on this, it got out, there's media and stuff like that. A Mexican surgeon approached me and said, "Can I come to your lab and learn how to isolate these pig insulin-producing cells?" I said, "Sure. That's what scientists do. We share our ideas." So he came, about a year later, he phones me and he says, "I'm doing clinical trials. Do you want to be involved?" I said, "No way."
Wow.
But then I get another phone call from an extremely wealthy person in Manitoba whose son is type 1 diabetic. He came to visit me and he says, and he was actually quite arrogant and demanding. He was saying, I want you to isolate the pig cells here and send them to Mexico so my son can be transplanted, because I don't want dirty Mexican pig cells. And I said, can't do it. So this guy was going to meetings, presenting his data, and we're all kind of like rolling our eyes. And that, in fact, damaged the field. Because all it takes is one group to go out there and do damage, and we're back to square one. They have, however, approved clinical trials in New Zealand. But, and I've seen minor reports, nothing really convincing, but they're saying that they've had some benefit and shown no problems with safety. But it's really hard to figure out that they're approved in New Zealand. The cells are produced in New Zealand by a company, but I think the transplants are happening in China and Russia. So I'm always extremely cautious. I have passion for cell therapy, and we're building a $26 million facility on the 7th floor of the LKS to actually transplant cells and tissues. It's going to be completed in June 2014. My concern now is I got to find stuff to put in there that actually has a chance to be. So I'm hesitant about a lot of things that I read in the media, but there have been advances, but it's not as promising as the media and the internet makes it.
I have a question. So, the Mexican surgeon, when he did the trials with the clinical trials, how were the results for that?
Well, so they did it in adolescent patients. So they showed that there was benefit, because when it comes to diabetes, we used to think that the Holy Grail was to completely get them off insulin. If we can give them better control of their blood sugars with taking less insulin, we have a very good chance of reducing the complications. That I consider a clinical benefit. The problem is when these 7 or 9 young teenagers entered this clinical trial, they went in and were working with a group of dietitians, doctors who see patients with type 1 diabetes, and they were most likely given much better health care, extensive monitoring of their blood sugars, better daily insulin injection. So was that simply the benefit? When you do a clinical trial, you have to have control that goes into the same group that doesn't get the transplant. That wasn't done.
Thanks so much, Greg. That's fascinating. Thanks so much for coming through that perspective. Next up is Pete.
So I feel a little bit embarrassed actually to be in this panel with a lot of stem cell experts. I should disclose first off that I don't have a specific research interest in stem cell therapy or medical tourism. I'm not formally trained bioethicist or anything along those lines. I really am a fairly run-of-the-mill community family physician. But I think that does afford me a bit of an opportunity to see a wide variety of different illnesses and conditions, as well as the numerous treatments, both conventional and sometimes unconventional, that goes along with that. And from that perch, I think it allows me an opportunity to see some of the challenges that might present both to patients and their primary care physicians in pursuing some of these therapies. So for my end of the discussion, I'm not going to probably weigh in, at least at this stage personally, in terms of whether I think patients should or should not be traveling for these therapies. I'm going to start with the obvious reality that patients are traveling for these therapies and talk about where that lands us. So the conversations that I have with patients when they come into my clinic can be very, very challenging. These are extremely emotional issues for patients, and we need to afford them the time to listen to what their personal motivations are in pursuing stem cell therapy abroad, to get as best an understanding of how they came to this point and what their expectations are. Unfortunately, frequently when patients present to their primary care physicians to have these discussions, there's oftentimes a preconceived expectation that they're going to be immediately dismissed, and that's an issue, and that we as physicians have probably not done ourselves a great service if that's the expectation. So we need to take time and have adequate conversations with our patients to understand what's going on. And at the very least, I think oftentimes we're able, in understanding patients' motivations better, to have a better sense of what the gaps in their care have been here and how potentially we might be able to optimize their care regardless of whether they're going to pursue these therapies or not. But I do think, at the root of this, though, I do think, maybe I've got a false belief, but a belief that most physicians really do want to appropriately educate their patients about the potential risks as well as the potential lack of benefits that they might face if they're traveling abroad, but quickly become overwhelmed when faced with sort of a general lack of reliable resources in which to help inform their patients. And sadly, because of that, that sometimes leads to I think sweeping and sometimes inappropriate generalizations about the field, and we need to be very, very careful about how we overgeneralize sometimes in these discussions. And if nothing else, we need to view each and every single one of these discussions as fairly unique. Each patient is very, very different, and we need to take into consideration what their specific diagnoses and prognoses are, what their current functional status is, previous therapies that have been trialed and what their current therapeutic trials are, and similarly what their social context is before we have these discussions or while we have these discussions with them. Despite saying that generalizations are maybe not our friends in these situations, there probably are some generalizations that we can use to kind of inform our discussions. And so, I think when I sit down with a patient, I first want to know what their pertinent medical history is and get as clear an understanding about that as possible, and move on, like I said, to really try and understand their own personal motivations and expectations. And then the topic of risks and benefits has always come up, or has come up previously. And whenever we're talking about any therapies in medicine, there always has to be this balance in discussing risks and benefits. And on the benefits side of things, there's a lot of potential peril when it comes to stem cell therapies, especially because of the sort of direct-to-consumer marketing of these therapies, and as Tim implied, largely through the internet. And this doesn't apply exclusively to stem cell therapies, whether it be direct-to-consumer, direct-to-patient marketing of antidepressants or knee replacements or whatever the case may be. We need to be very, very cautious about that. There's again, as Tim implied, there's a lot of advertisement on provider websites suggesting that a single protocol or a single therapy might be applicable across an extremely broad variety of conditions. And the reality is that the pathophysiology of all of these conditions is so diverse that to expect that a single protocol or a single therapy might apply to absolutely all of them and be both safe and efficacious is really unrealistic. So we need to be cautious about that. And similarly, if we have some questions or some doubts about the information that might be provided directly from the providers, there probably needs to be some caution about the faith or the stock that we put in patient testimonials, people who've traveled for some of these therapies and have returned. And certainly I wouldn't imply that patients who've gone and pursued these therapies would be intentionally misleading to any of their cohort of individuals with similar conditions. But clearly the weight of that is not the same as participation in a registered clinical trial. So there is a difference there, certainly, in terms of the evidence that's provided. When it comes down to risks, well, risks are a challenging one. And again, when you look at how some of these therapies are advertised, they're frequently pitched as having no risk. And my own personal experience, I don't know of a single medical therapy I've ever encountered, whether it be stem cells or not, that comes with no risk whatsoever. And anything that's being advertised, especially directly to patients, as having no risk, I think obviously needs to draw some skepticism, both of the therapy, but also the motivation of the people who are offering it. If patients do choose to pursue these therapies, then I really think there's significant importance in trying to have patients establish as best possible, what specific procedure or protocol is being done. And frequently we'll find that it's a great challenge in getting the specifics out of that, but I think they need to know as best possible exactly what's being proposed for them. In addition to that, how complications are going to be reported and potentially managed. And what the anticipated follow-up is. And follow-up is a big potential issue from a primary care perspective, because many patients returning, having received some of these therapies, there will be some implied follow-up that's required. And frequently that falls on the patient's own primary care physician to do that. And it's clear that on occasion some of the follow-up that's requested really either may not even be available or recommended back in a patient's home country or home location. And so that really needs to be clearly established beforehand. Beyond that, there are probably some very sort of more technical nuts and bolts aspects of medical tourism, and the fact that it really combines a couple of different things. Both it's the procedure that you're going for, but it's also the aspect of tourism, and so medical tourism is patients frequently with reduced functional capacity and status traveling abroad, and what is the safety and stability of their medical conditions and ability in doing that. And so sometimes from a primary care perspective, it may be as basic if a patient has made up their mind to try and ensure as best possible that their appropriate travel vaccinations are in place, that they've had adequate consultation beforehand, an opportunity to have a baseline assessment done so that we may monitor what, if any, benefit their therapies have had on arrival back home. But at the end of the day, I think my role primarily is, and I'll clarify, but is one of support. And I do think as primary care physicians, we have a role in supporting our patients, trying to provide them with as much education as we possibly can about these therapies, despite the fact that there's just an overall lack of good quality support and evidence out there. And that's different than a wholehearted endorsement of these therapies, but it's definitely important in maintaining, I think, a healthy patient-physician relationship on return from travel, which is going to be a necessity pretty much for all patients. So that's my 2 cents worth.
Thanks, Pete. Charlie?
Hi. So I would like to declare very much the same things that Pete declared. I am by no means a researcher at all. So I took my take on me being invited was I'm here to speak about desperation and hope. And so from one organization, and only one organization's point of view, when you think of the many illnesses out there, Alzheimer and dementia, Dr. Alzheimer discovered a type of dementia 107 years ago. This disease to this day still has no known cause and no known cure. So the family members that we work with, and we refer to them as family members because they are people, they're not mice or anything else, they're the real live ones, walking, talking, heartbeat ones. So they're the people that we work with, so the families who are truly desperate. 5 years ago, our national office commissioned a study for Canada. At that time, we knew there were 500,000 Canadians who had some type of dementia. They forecasted to this year, and we know that there would be 747,000 people in Canada who have some type of dementia. Probably fairly replicated in this room. 72% of the people who have dementia or who have Alzheimer's disease type of dementia are women. And women also make up 61% of all other types of dementia. At the age of 65, 1 out of 11 people will have some type of dementia. So I'm guessing most people in this room plan on making it to 65. I think I have some pretty good family genetics to get me actually quite a bit farther. But at the age of 85, 1 out of 2 people will have a dementia. So the families we work with are desperate. The other thing I think we need to look at is our change of how we view health as a population. And if you look at it, you can read almost on a daily basis concerns about long-term care beds, whether there's going to be enough, the type of care you're getting. And seniors in our day, they're still going to those care centers. But I can tell you, baby boomers, and many of you sitting in this room, you do not ever, and this is what we're told, they do not ever want to go to that type of a long-term care. They do not want that to be their future, which adds to the desperation of families. Whereas, you know, if we think of people in their 90s, we tend to say they've had a good life. They're 85, they've had a good life. Baby boomers want to be at 85 and not thinking about, well, it's okay if I spend my last years in a long-term care center. So there's a real change of, I guess, drive of emotion from people out there as to what they want. Again, in the families that we work with, a big rising population is people who have early onset dementia. So those are the people who are diagnosed before the age of 65. So we work with families diagnosed at the age of 40, at 45 in long-term care. We work with families who dad has dementia, no longer recognizes his 3-year-old, his 5-year-old. He fights constantly with his 10-year-old and 14-year-old because they actually have to get the kids to school, but he still is trying to be dad, but he actually doesn't have the ability to do that. Mom comes home from working, there's only a one-income family, she's wiped out, she has to contend with 5 kids as well as her husband who really functionally can't do anything. That would be a pretty big example of a family who's desperate, who would probably go to any length to get any type of treatment that they could change this whole focus. So we're not talking about 85-year-olds only that have lived a good life. We're talking about children, we're talking about us, and I think we see that desperation. When we read things in the media, that's where people have their hope then. So they're pushed to a brink of desperation, and then they read in the paper, I could go someplace and maybe be cured. So what will it take me and my family to make this happen? As Mbaka said when he introduced me, our role is to help educate families and provide information and support. And I have to say, it's not many family meetings that I don't get asked. So, about the treatment, like how close are we with this stem cell? Because that's what they read about, and that's the cure-all out there. And for our families, the only medication they get gives them increases their quality for 1 to 3 years at the most. So again, the huge desperation, and they read things in the paper. They know about the Edmonton protocols for diabetes. We know about all these wonderful stem cell things happening, and they're desperate to have it. And I think that's their hope, because they are diagnosed, again, with our disease only, with a disease where there is no cure. If you look at cancers, at least some of them there's a cure, and some we can live for a few years with very good quality. There is no cure. So the families we work with are very desperate for anything. So when they read, for 50,000 plus travel, there could be a hope. It's tweaking people's conscious. And even if we're looking at mom and dad, you know what? Again, we don't want to live in those long-term care centers, so we'll do almost anything possible to drive to do that. So the hope for many people is stem cell research. I think the sadness is we're 100 years away.
Thanks, Ollie. So as you can see, we've covered pretty much every aspect of this topic. Our experts have covered every aspect of this topic. And I invite you to ask questions during the discussion. Be provocative, be controversial. If you disagree with any of them, tell them. This is the one chance you get. And sure.
I'm fascinated to hear any kind of proposals for how we might help to improve the situation of people's education and ability to make good decisions on this without resorting as a first line to further regulation?
You know, it's a great question, and it's one that our team is actually fascinated with. One of my colleagues, Zubin Master, who's now in Albany, we did a study of the education material from both disease groups, from professional organizations, and we felt that was missing. It's interesting, because Greg touched on this. Was there's almost no explanation of the scientific process. People think these therapies are being withheld, and you see this in the discussions, or there's some kind of bureaucracy, like regulatory bureaucracy, keeping it from them, and that in China or India or other places, they're not worrying about that bureaucracy. They're acting now, right? And I get angry emails, right? And that's the tone of the email. So I think it's really important to, and we should maybe even be starting right with kids. Right, in elementary school and junior high, explaining that scientific process. There's great studies that, Greg's touched on this, that how rare it is to go from an animal study to a clinical trial. That step's rare, right? And then to go from a successful clinical trial to an actual therapy, phenomenally rare. And no one's playing games. No one's trying to withhold. There's not some great conspiracy trying to keep this therapy. So I think that we found that story is missing. Having said that, there's a lot of research around this thing called the deficit model. And in fact, educating people often doesn't change their mind. Once they've decided, particularly now that you have this fragmentation of the media, you can go and find something online that is going to confirm your already established belief. So it becomes very, very difficult. So I'm a little pessimistic on the one hand, but ever optimistic that over the long term we can improve the situation. So, sorry, I shouldn't go on so long, but the other thing I want, and this is maybe generate some provocative discussion, and builds on something that challenged Pete a little bit. I wrote an article called "Should We Call It Fraud?" Because what's forgotten here, it wasn't really brought up. You think about these clinics; they know these people are. I'm not saying every clinic's like this, and I've met providers in Mexico. But somewhere there are frauds that are taking advantage of people at the worst time, right? It's unbelievably criminal. Like it's enraging, and that part of the story is often left out. And I think we need a little bit more of that rhetoric out there. That, look, this isn't just some experiment. This is a group of individuals trying to steal your money at the worst time in your life.
If I can just make a point about education, I think it's difficult to educate desperation. Give you a personal example. In the past 6 to 8 months, 2 extremely wealthy brothers, both with type 1 diabetes, in their early 70s, really want me to get my pig islet research into the clinic so I can transplant them. One of them is even a surgeon, or was a surgeon. So he's got to be educated about medicine. But I constantly get phone calls, emails. They want to throw money at me. But I can't take it because I can't promise them that. A lot of researchers would take it, knowing that you can't deliver what you say you can. But I think there are a lot of people out there, if you're desperate, you've got tunnel vision.
I was going to look at it from a primary care perspective and the physician perspective. Physicians sign an oath not to do harm, right? And so surgeons and physicians who are doing these types of treatments, there is a regulation or a way to regulate them based on that oath that they take.
In an ideal world, that would be wonderful. Yeah, and certainly I feel compelled myself by that similar oath. But I think, as Tim points out, the peril is that, unfortunately, despite that, physicians are people like any others, and money is a particularly large motivating factor for people. And I think, at the very least, there's people who are participating in overt fraud, and probably some who are deceiving themselves that they are in fact providing some good. And and it ties into, you know, I think many patients are traveling as well with the belief that engaging in some of these therapies might be helping to further and advance the science in the area, that they're sort of being trailblazers, and the reality is, you know, these therapies are not being published. The results are not being looked at. The reality of this advancing the field is, I mean, it's unrealistic, and so there's a balance, I think, between fraud and just irresponsible practice, and who's convincing who what.
We have Amy Zarzechny just got a research grant. She's another colleague of ours. She's at the University of Regina, to look at this very issue, to look at who are these doctors, right? And are they doctors? And if they're doctors, is there a professional body that can be engaged? Now, in the U.S., as Pete Comey knows, they've actually gotten more aggressive, and they've actually criminally charged some doctors who are just involved in sending patients to these clinics. So that's, you know, those are good news stories. Pete brought up a really interesting point about the responsibility of doctors here. There's a fascinating tension that family doctors have, because you want to maintain that physician-patient relationship, but at the same time you want to be completely forthright. That's a fascinating dilemma for family care doctors. You don't want to alienate them, but at the same time you want to be blunt, right?
Yeah, it's a huge issue, and so it's like I said, I think it unfortunately we don't do ourselves a great service. We like to think that we communicate very, very well with patients about these things, but we get intimidated quickly about our own potential lack of knowledge in some situations, it's a constant battle in terms of how you walk that line between being blunt and as straightforward as possible, presenting information at the level that's easily understood by your patients about what they are potentially getting themselves into, while still wanting to ensure that that patient has somebody to come back to when potentially the wheels come off of this whole process, and they're in real desperate and dire need of further help and assistance.
And I think we see that, and we see those family members who feel that they're general practitioners. You know, we hear stories, well, my doctor just told me this is what I have, and there was nothing they could do, and they escorted me out of their office. Well, in our disease, there isn't a lot to be done then. Here, you can use this medication for a year or so. But again, it's because of that human issue where I think they're again desperate people, and very much as what we said, it's hard to sometimes educate desperate people. So doctors trying to give it to people straight, easy, simple to understand, can be taken as they're cold-hearted, they don't care. Doctors trying to be warm and gentle, well, they're beating around the bush. To me, I feel very sorry for a family, because there's so many personalities and so many things, but again, they're dealing with desperate people who just want any little olive branch to be given to them.
My question is for Timothy and Obaka. So, I think a couple of weeks ago, I attended a seminar, and Glenn was also there. There was this one guy who has done stem cell and treatment work. So in your research, have you looked into some patients where the stem cell has worked, and try to get some information about I agree that these research hasn't been published because if it was published, it would have been a Nature paper for sure. But how did those treatment work?
Well,
did you get a chance to talk to those patients other than the doctors?
I did, yeah. To say it worked is not something anyone is sure about. We do see a lot of reports from patients where they say we went for a treatment, it worked. We've also seen news stories where a patient would go for a treatment, come back and say, look, it worked. And then 2 months later, there's a follow-up story where the patient says, this didn't work at all. I'm back to where I was before. So we see a lot of those stories. It's difficult to assess what worked or what didn't work. When it's self-reported, you usually can't convince the person that what they're experiencing is different from what they're experiencing. But how do you take that and turn that into health policy, or how do you take that and turn that into a message for the general public? Unfortunately, you can't recommend treatments on the basis of anecdote, on the basis of what somebody feels it's happening in their situation. We also know of the placebo effect. You know, you can't be exactly sure what the person experienced or what the person received when they went there. You're not even sure if they got saline or stem cells. No one knows. So it's difficult to assess those stories. While it's also, as you probably observed at that event, it's also difficult to try and engage with a person who feels that they've experienced something.
Right, yeah, it's definitely difficult
right.
to understand. Yeah, maybe.
Do you have a comment? Sorry.
Well, I mean, that was fascinating, and I was so glad they came, right? Because that really demonstrated this is a real phenomenon, right? So I found that a really rich experience. He's another really good example because that gentleman also got the liberation treatment. So he got stem cell and the liberation treatment. You don't know what else happened at the clinic, right, Greg? So this is not, a clean clinical trial. This therapy worked.
Right.
Who knows, right?
Right.
Now, we've been so, negative. I am a believer. I think stem cells are going to deliver. I do. It's going to take a while. Something's going to happen. It's an exciting area, right? It's going to. Who knows? It might even end up working like a pharmaceutical. Almost,
But
right?
what's lacking is, for example, 10%, or let's say even 1 or 2 patients, it works in. Who's going to look at those patients to figure out why it worked?
That's true.
That's lacking.
Well, so the interesting thing about MS, and I'm optimist. I think that's an exciting area. They are, as Greg mentioned, they're at early stage clinical. They're stage 1 clinical trials, right? So it is an exciting area, and it's not like Alzheimer's. It's a relatively limited number of cells, so to speak, right, Greg? So it's an exciting area. You know what's going to be really challenging? 12 years from now, 15 years from now, when they are close to the clinic, and they have these clinics in China and India offering them, that becomes even more challenging from an ethical and you follow that? When it is close to the clinic, what do we do? It becomes a lot more difficult to tell the patient, don't go. Right?
And we've studied providers in places like China who actually say, we're going to start by putting this in people, and then we observe what happens to them, right? So that's the other problem. When you put yourself in that kind of position, you're basically being used, you become the model for studying the disease. And then there's other things that go with it that nobody's actually assessing. So it's difficult to know what exactly it is that you're receiving. It's difficult to know what kind of information the patients get when they go for these treatments. And when they come back and report these things, it's unclear what they received. It's unclear what information was given to them. It's unclear. Nobody follows them over the long term to try and determine if the treatments worked or didn't work. You just have to take them by their word. It's tough.
Did you?
Yeah, a little more sciencey, but what's the supposed source for the majority of the therapeutic stem cells?
Sorry?
Like, what's the source? Is it animal, human source?
It would, for most of the clinical trials, it's all human.
But how about these kind of shady clinics in China?
See, that's a good question. What is the source?
We-
So, for example, if you wanted to do a clinical trial in Canada, one of the things that Health Canada would say is for you to release the product or the cells, you need to do quality assurance and quality control. What are you transplanting? And that has to be the same all the time. In these other clinical trials in all these different countries, they don't know what they're transplanting. Most of us who are working with stem cells don't know what we're working because all the cells in there aren't the same. So they're missing the most basic criteria that Health Canada would allow us to do here. That's the most basic thing.
Should a clinical trial go forth here, what would be the source? Would it be like from cadavers or embryonic?
It would depend on you could be autologous cells, you could do embryonic cells, you could do IPS cells. Have you heard of that? Induced pluripotent stem cells. So that's taking a cell and so it all they're right now we're both part of the stem cell network, UBACA also, and they're coming at it from all different angles, right? They're really trying everything. But Greg's right. I'm blanking on her name, Greg. There's a famous stem cell researcher from Sweden, and you can see the YouTube clip. And she put out an offer. She said to all the clinics of the world, send me your samples, what you're injecting into people, and I will test it and I'll tell you what it is. No one, for free. This is a world-renowned stem cell researcher. Nobody has sent the samples. Could be saline. Who knows what they're putting in? I think, you know.
Tim, do you want to comment on what we've seen in our research? What the sources are that we've seen from our research?
Yeah, so they claim on their websites that it is everything from fetal to embryonic to autologous to IPS. So you have these clinics claiming all the sources. And
we've also seen plant cells for cosmetics, and like
apple
stem cells.
Other questions? There's lots of food, by the way.
Yeah, there's food and drinks. It's your money, so enjoy it. So feel free to start up anytime you want and get a drink or get some more food. So sure, go ahead.
I have a question, I guess looking into the future a little bit. So just picking up on some of the numbers that were mentioned, say, 80 to 100 years until this is an effective way to treat people. How do you think it might be possible to sustain public interest and a sort of, and with that, I guess, funding into that area for another century, basically, until you actually have a tangible benefit where even things that only have seen maybe 40 years of research over the last 40 years, people are getting frustrated with already.
Yeah, that's an awesome question. It's one that we're very, very interested in at our center. There's something called the scientific bandwagon. And you saw it with the Human Genome Project, you saw it with nanotechnology. You're seeing it right now starting with neuroscience. And it's this idea that you've got to build up interest, and that interest has got to be sustained. And you're either with us or against us. And so when I was researching my book, there's these great quotes that scientists told me where very famous scientists said, stop saying these negative things about our field because the money will just go someplace else. So I think that the whole, this hype phenomenon is starting to be recognized. And I think the scientific community, I don't know if Greg agrees, at least I don't want to be careful to start naming countries, but I think it's getting a lot better. Do you agree? I think
it is. Okay, give me an example. Like the Stem Cell Network, which has been around for over 10 years, right, has created an excellent group of stem cell scientists in Canada, in the ethics, in the science, and all different disciplines. So I think it's a really strong group, and the nice thing is we work together as a group. And the momentum's there, but it's like the bandwagon. What's hot now, everybody jumps on it, and then something else comes out, and then people jump off on that. And curiously, what happens is it always goes full circle. Because what people, I read reading grants about people's ideas, what they wanted to research. We were doing this 25 years ago, but now it's a new idea.
I will say this, and I've asked this group this. I mean, you guys we're in an academic setting, maybe not a great, you're a biased sample. But research has shown that the general public understands. You don't have to oversell it. They understand the iterative nature of science, and they're willing to invest in it now for future generations. So I don't think we have to oversell it. I think people understand, and so I'm ever the optimist. Do you guys agree with that? You think the public understands? You guys.
We're biased. I was going to go back to the issue of like raising the expectations. Like, so the media and the academic world raising the expectations of patients and family members for the successful therapies and how that impacts the funding and the policy making and all of that. So the media has made this is going to be huge, and now patients are saying, well, we expect it, we want it, we want the healthcare system to give it to us. And so the policymakers and decision makers and primary care physicians are going to have to do something about that expectation that this is going to work. So how do you balance that creating that patient expectation and the healthcare resources to later be able to provide this service to 700,000 people that may have dementia? Right?
I mean, it's a huge problem. And again, this is a phenomenon that we've studied. And it's happening right now in personalized medicine. How many times have you guys heard about stem cells? It was particularly bad in this area because the way stem cells unfolded. It was a controversy. So you had people saying this is unethical, it's immoral to do this research. So you had that side of the camp. And then on the other side, you had scientists who had to hype it even more, right? Say, we're going to save lives if you aren't going to allow us to do, and so that rhetoric that was almost political in a sense, right? Was put out there to counter this negative stuff, lived on, right? It lived on, the hype lived on. And the other interesting thing that's happening right now in science is the economic hype. So people are saying, invest in stem cell research, it's going to lead to, you saw, there's great quotes from the UK, it's going to lead to 10,000 jobs, right? Which is totally baloney, right? So that's what the patients are seeing. And you can completely understand why they would expect the therapies tomorrow.
Yeah, yeah, and they would expect our taxpayers' money to go to more trials and to go to more services. And how are we going to manage that expectation? I mean, the healthcare system is already almost bankrupt. How are we going to manage that expectation that people have?
I know what we did, it was probably 3 years ago, we actually joined with, and I can't even recall who it was, but with some researchers, people who are doing clinical trials, not necessarily stem cell. We had some people talk about stem cell, but also even just pharmaceutical things, because again, our families think there is regulatory agencies holding things from them. And so we actually held a public forum to help educate some of our families. And some actually got up and left when one of the stem cell researchers said, it's 100 years. And they left and they said, like, we're not mad. I just thought it was so much closer. I don't need. Others stayed and said, well, we hope this will help our children or grandchildren. So I do think some also get that we also are doing this for the future. But yeah, we just felt the pressure because, you know, our role is a certain role, but it gets to a point where, like, I can't talk about stem cell research. I'm not a researcher, but every time I pick up my phone, and the third phone call is, well, I read in the paper what's happening with this, right? So we actually held education information sessions, which weren't, again, a great news for the families we work with, but at least educated them to know that, you know, it's 80 to 100 years away. You know, if you're hearing these things, and even for drug things, you know, well, I heard there's this new thing out, how come it's not in Canada? I read it's in China. Well, it's going to take 30 years to hit the market here if it does. So again, just to give them a realistic expectation. And again, some I think, you know, I think you said it, it's not only are they desperate, but I think some people, once they've got it in their mind, some people still left and were sure that government is holding out on them. Yeah. And others left educated that, shucks, I thought it was closer.
Well, unfortunately, the government's holding back on funds for medical research. So it's really difficult in this environment to get money to do your research. Because as a researcher, the university doesn't support a thing in your lab. I have to even pay for my phone. So it's all from writing grants.
Yeah.
So, sorry. I guess I have a question for that. Like, we keep saying China bad, but
Mexico. Give it time. You have to finish your drinks.
No, but there's so much coming out of China, and I'm assuming it's a lot more than that's coming out of here. So are we looking at any of the research and the innovations that are coming out? Like, is there someone else that is ahead of us?
Yeah, look, you know, China and India actually are fascinating case studies because, Greg can talk to us, they have both cutting edge stem cell research going on there, like leading stuff, right? And they have this going on. So for them, it's a policy dilemma, right? Because they want both, right? And so absolutely, that is going on. That's going on there. And the other thing is that you know, one of the criticisms I often get is, you know, you're being Western centric, and we shouldn't be holding the China to your view of knowledge, the Western view of knowledge. I don't buy that. Like, maybe if you're talking about complementary alternative medicine, I don't buy it there either. But that is, but at least it's an argument. These clinics are saying they're part of the scientific community. They can be held to the same standard as any place, right? And so I think it's A, legitimate to hold these clinics to the same standard, and B, there's great science coming out of India and China.
Yeah, I agree. We've also studied what the Chinese media thinks about some of these providers. And the interesting thing we found is that the providers actually control the message. For the most part, they're the ones who put out the message that it's legitimate to come to China and get this treatment. So it's marketing in a sense. They use the media to do their marketing. And you have to be suspicious about that, but that doesn't, sort of detract from the fact that in China there's good research going on that's going by the same standards that we use to assess medicine here. I don't think scientists in China think you should start by putting things in patients first and then working your way back. They believe in doing things in the usual way. And if you talk to them, I've met some at conferences where they say, we are against that happening, we're against people doing that, and we don't even know why these clinics are doing that.
Might it be known in some parts of the developing world, it doesn't necessarily have to be, India, actually Indonesia comes to mind for me at the moment, but if there is any evidence of any political will to try to do things like STEM, organ donation, for example. Certainly we know that the impoverished, for one example, can be very, very motivated by the cash dollar figure that is put in front of them to part with a kidney.
I think there's a little bit of good news here. So there is good news. Like for example, and I want to be careful not ranking countries, but Costa Rica has shut down 2 clinics. Is that right? Yeah, they shut it. So I think they are. We're seeing it increasingly happen. But so that's the good news story.
Yeah.
The good news story is that they're shutting down. The bad news story is these clinics seem to just pop up someplace else. Yeah. Same, different name, same companies. So it is what's that game called where you hit the guacamole? Yeah. So it is a little bit of that story, but I think that increasingly these countries are noticed. They also want to be legitimate. They want to be part of the scientific community, and they recognize in order to be part of that scientific community, they've got to step it up. Now, and also a lot of these clinics are in the U.S. right now, and the FDA in the United States has very recently, as a result of a court case, said that we can regulate these clinics now. This is under our jurisdiction. Stem cells are a drug, so we can now regulate these clinics. So what these clinics are now doing is sending patients to Mexico and other places. So the clinic stays, the home office stays in the United States, and then they do the procedure in Mexico and the Caribbean.
So I wanted to comment on the case we saw recently where a patient got some kind of stem cell treatment, and then he was disabled from Crohn's disease. Right.
You go ahead.
Okay. But this is a patient in the U.S. who had very debilitating Crohn's disease, and he received some kind of non-embryonic stem cell treatment, and he reported some improvements. But the unfortunate news is that his improvements over time, he relapsed. He felt a little bit better, but he relapsed over time. But he applied for disability benefits after he got the treatment, and it was refused. So he would have been eligible before he went for the treatment for disability benefits. But after receiving the treatment, even though he didn't get the kind of benefit he was looking to get, and he actually was the one who applied for it, saying, I'm still disabled. The government simply disagreed with him and said, no, you got enough improvement to take you out of the zone of disability, and you are no longer eligible for this benefit. So there are some other kinds of consequences to some of these things. That's my daughter. That's the present. So there are some other kinds of consequences to going for these treatments that go beyond just the medical effects as well. In this patient's case, he actually sued to try and get his benefits, and the courts said no. You have enough improvement to take you out of the range of disability.
So as law professors, we find this fascinating because this is the court getting the science wrong, right? The court believed the stem cell hype and therefore said, you got stem cell treatments, and it was 2002 or something, like crazy, like early days.
Yeah,
right?
early days.
And now the court's still, lawyers take forever. And it's, so think about that. The court bought the hype and as a result of that, denied coverage. Fascinating. So it really shows how embedded this problem, this phenomenon is.
And it didn't occur to anyone, at least to the judges, that this is the person who went for the treatment, who's applying here to get his disability benefits. If he was no longer disabled, there's no way he would want to do that. And it was clear that he was still suffering from something, because they said, before you couldn't go for 6 hours without resting or going to the washroom, but now you can. So that's enough of an improvement that we can. It's fascinating. Any other questions, comments? Now that my daughter stopped crying.
And there are still lots of food, so we can all mingle after.
This is perhaps more in the line of comment. I've been involved delivering healthcare to a refugee population. There is a certain individual that comes to mind. Now, this individual, clearly according to the reports abroad, was definitely in end-stage renal failure and got his kidney in the developing world. Gets here, is very, very unstable. Now, I'm only just giving one patient example, but it's leading me into the broader picture, and that is, again, persons who choose, this individual didn't choose this, but based on his medical condition, but anyway, to seek some of these treatments abroad, come here either because they're original citizens and residents or because they are allowed into Canada under a bona fide status, and then. So all the sequelae that comes from that, and the impact on the healthcare system.
Yeah.
A healthcare system that, of course, we are all trying to deal better with. Thank you.
Yeah, I think it's a good comment, and clearly there's a size. It can potentially be a sizable impact.
Yeah.
I don't know myself whether we've done a good job of quantifying exactly how much of an impact it's had from a health resource sort of utilization perspective here, encompassing all of the medical tourism that happens. You guys are probably more familiar if there is something built up there. It is a huge challenge, and so the expectations frequently in patients returning. There's no question that there will be patients returning who are acutely unwell, and there is the reality that we have an ethical obligation to look after those patients. I don't think anybody would argue that whatsoever. The flip side of that, however, are there may be patients returning following therapies that have been told that they require some specific aspects of follow-up that their attending physicians here might question the utility and the value of. And so how do we go about managing that? And that's why I think this discussion is so important beforehand. If we have patients that are traveling abroad, at the very least, we need to understand, whether we discourage it or not, understand what the expectation is on when they return back, because they need to clearly know whether this is even feasible for them, because oftentimes it's not.
I mean, it's a great question, and we're part of a big CIHR grant that hopefully will get funded. We're going to know soon on this. Part of it is this very topic. It's a transplantation grant, and we are working with a health economist, Scott Clarenbach, who wants to look at this very issue, right? Among other things. And it is a fascinating issue. Now, I've actually run into some transplant people that say, look, if I tell my patient, do not go there, and explain that to them, they argue they shouldn't have to take care of them when they come back. We warned you. You knew going in, and one of the things we said, if you go get this, I'm not taking care when you come back. Well, Pete's right. From an ethical legal perspective, you can't do that. You can fire a patient, as it's often called, but it has to be done in a way that doesn't prejudice the patient. And the problem with something like transplantation in a small jurisdiction, it's not a lot of options, right? So you're likely often going to be stuck with the patient and have these legal obligations to them. So it's a great point.
Thank you.
So we have an online question. So I've been live blogging this event. A few people I think paying attention. I've tried to add some color here and there. So I mentioned that the moderator's child was crying. So the question from the blogosphere is there stem cell treatment for cranky kids? That is the actual question we got.
Possibly. Yeah, maybe. I don't think it'll work though. Yeah, when she gets going, ice cream helps. Ice cream, yeah, it's called ice cream. Should we wrap up? Yeah. Well, I'd like to thank panelists for very, very exciting and interesting discussion. I know a lot about this field, but I also learned a lot of new things today from just listening to them speak about this issue. I also like to thank all of you for coming and for your great questions. I do encourage you to have some food before you leave, have some drinks. We've paid for a ton of drinks, so please do. Sorry? Oh yes, the survey. We also handed out surveys. It would be great if people fill that out because our funders expect us to report back on this event. So please do take some time to fill out your surveys while you're just including some drinks. But I'm really grateful to our panel of experts for taking the time on a Saturday to come here and educate us on this topic, and for all of you for coming out as well. This, I think, was a very good event, and there'll be more in the future. Stay connected to the Health Law Institute and the Health Law and Science Policy Group. We put up this event from time to time, and we always looking for people to come and engage with us for the work that we do. So thank you again, and have a good evening. Thank you, Rebecca.